When you think about it, I mean, I think kidney cancer is traditionally a very VEGF-driven tumor. The story goes back to the VHL mutation, which is common in about 70% of patients with a clear cell kidney cancer, which is the predominant cell type for patients with advanced disease. So patients with a VHL mutation are often overexpressing hypoxia-inducible factor, or HIF. This leads to the production of a variety of proteins, including VEGF, which make these tumors very vascular. Traditionally, that's made them resistant to things like chemotherapy and radiation, but more sensitive than most other solid tumors to targeted therapies that go after VEGF signaling in one way or the other. So that biology is common, and that's where VEGF has a role. Anti-VEGF strategies have a role. But we've also known for a long time that kidney cancer is a rather immune-responsive solid tumor, where you can actually see in some patients lots of infiltration of their tumor with immune cells at presentation, and you can also see spontaneous remissions in rare cases after surgery, which may be through an immune mechanism. That led to the development, those insights led to the development of first cytokine-based immune therapies, which would produce dramatic benefits, but also significant toxicities, but the benefits were only in a small number of patients. Now with this immune checkpoint blockade story, we're actually making much bigger gains on the immune therapy side. So we're actually able to take these immune cells that are already at the tumor but not killing it and unleash them to actually produce significant benefits in a subset of patients.
Combination therapy is becoming the cornerstone of kidney cancer therapy, much like other solid tumors, where the paradigm for cure, say in testicular cancer, has been multi-agent chemotherapy. And not single-agent chemotherapy. So in kidney cancer, we're moving towards a time of not just one monotherapy, which is unlikely to cure, but some of these checkpoint-based combinations, especially combinations of immune agents, have the potential to cure, and therefore I think we're willing to put up with a little more toxicity from combination to achieve cure in a fraction of patients. I don't think all patients need combination therapy. It's a great question because there are probably patients who can get away with monotherapy. I certainly have patients in my clinic who had been on trials of monotherapy who are doing well many years later, some of them in CR or near CR. So we don't know. We haven't done the trials yet. We sort of jumped in with combos in these phase 3s, which are turning out to be very active. Now we're going to go back, I think, and test monotherapy in a subset of patients. And like anything, there'll be patients who need more intense therapy and patients who can get away with less. And obviously, we should give them the least intensive therapy that gives them the best outcome. So I don't think all patients need it now.
I worry that we're going to, with all this exciting new data over the last year with combination approaches, that we might get to the point where we're sort of applying them in a blanket way and not specific for one patient or the other. We can still see dramatic benefits with single agent therapy, both VEGF and immune checkpoint blockade in trials. So there may be some patients who only need single agents in the beginning. There may be patients who benefit from a VEGF plus PD-1 strategy, others who need a PD-1 plus CTLA-4 strategy. And we need to figure out who those patients are, because there are going to be significant costs associated with combinations, more toxicity associated with combinations, and it may be that not every patient needs that approach right from the beginning.